Hi, everybody. We're going to give it just a couple minutes for everybody to join. Welcome, welcome. I see some of our Genève doctors attending, which is great. Glad everybody's here. I will continue to admit people as they come on in, but we're going to have so much to cover tonight, so I want to go ahead and get started. I'm Dr. Lisa Savage, for those of you who may not know me. I'm one of the medical directors at Genève, and we are an online clinic for menopause management. We have doctors in all 50 states. So if you're not familiar, please check us out at geneve.com. We welcome referrals and we welcome collaboration. Tonight, I'm really excited to talk about our topic, mood disorders in menopause, and especially glad to have a special colleague here, Dr. Nicole Scott. Dr. Scott has a very impressive resume. She has a degree in biology and secondary education from Vanderbilt. She has her MD degree from the University of Texas at Houston. And there she had a concentration in medical education. So you can see that educating is part of Dr. Scott's interest, and we're in for a real treat. Her residency was done here in Austin at the UT Dell Medical School. And during that time, she had a focus in women's reproductive health. So Dr. Scott is a practicing reproductive psychiatrist. Who better to talk about mood disorders in menopause? On a personal note, Dr. Scott, Nicole grew up down the street from me, but I'm aging myself because her dad is my contemporary in the Austin medical community. That makes me very happy, though, because what we're doing is we are bringing on the next generation of excellent doctors who are going to take care of us and our patients and our daughters. So special welcome to Dr. Nicole Scott.
Thank you so much, Dr. Savage. I so appreciate your invitation to be here, and I'm so excited to talk about something that I could talk about for far longer than we have time for today.
Well, we can have more of these. We can, especially if there's interest, we can have another one. Maybe we can distill down a couple of particular topics, more about mood disorders or more about other mental health issues that people are interested in. So yeah, we'll get started, and we have a few questions that we're going to just have a conversation about. If you will, please put your questions in the chat. And at the end, I'm going to try to leave plenty of time to get to the questions, because I know those are always fodder for more conversation, bringing up specific scenarios or specific questions. So we definitely want to get to those at the end. Put those in the chat if you will. And Dr. Scott, if you want to talk some more just about your practice, what do you do in your private practice? How is that based? Who do you see? Who do you work with? Tell us more about that.
Yeah, absolutely. So I work for a reproductive psychiatric clinic. So we are at the outpatient setting, and we take care of folks throughout the lifespan. So that means that we work with women around their menstrual cycles, a lot of pregnancy and postpartum mental health work. And then we work with folks during perimenopause to make sure that we are adequately taking care of mood and anxiety, bipolar disorder, psychosis, all sorts of stuff that might come up with those hormonal changes as they arise over a woman's lifespan. So that is primarily, that is my day job. And I find that not a lot of people, including other physicians, really kind of have a sense that that's a thing. A lot of folks are kind of surprised to hear that that is indeed a niche out here that we are filling. There's not a lot of reproductive psychiatrists, but I've started to at least learn enough of them that for the most part, I know some folks in most other states. So when my folks leave Texas or they're coming to me from out of state, I've got some colleagues elsewhere to connect with. But we are located, like I said, in Texas. And so we do take care of folks within the state of Texas right now. We don't have anyone with outside licenses, but we do try to keep up that networking as best we can, since we're somewhat specific, and try to help people get connected to services elsewhere when they need them. But yeah, that's what I spend my time in, kind of the outpatient setting, seeing women across the lifespan.
That is so great. I wish we could get you guys to get licensed across many states, because we could fill your schedule, guaranteed. I've been so fortunate being here in Austin, that Nicole and I have gotten to know each other, had coffee, and have, that collegial relationship, and we share patients. So I'm lucky. I get to actually send patients to Nicole. And she sends me patients as well. So, collaboration at Genève with other physicians in whatever specialty is really important. So that's been very special. I've appreciated that a lot.
It's been so awesome to have you guys to send folks to, because I mean, in any community, but a lot of times people do have trouble knowing where exactly to go, and their OB maybe doesn't have all the information, or not the time to give them all that information. And so I've loved to be able to say, I know where to send you. I know where you'll get the information you're looking for, and they have time to explain it to you. And I love getting your notes back too, because I've learned so much from the information you send back to me about the choices you're making and what you guys are doing together. So I'm learning right alongside my patients.
I love that. And, I like sending notes to referring physicians, because I always liked reading those on my patients from a referring physician. Like you said, you learn something. And part of our mission at Genève is always educating not only our patients, but also our fellow clinicians. And on that note, this webinar is free to share when we're done. It'll be available to watch the recording, and we intend for it to be shared widely. So please feel free to share it with colleagues in your group or others who might be interested. We welcome that. All right, Dr. Scott, so let's talk about the prevalence of mood disorders across the menopause transition. What do you see? When do you see it? Who do you see? Tell us about what emerges or is the most prevalent. Is it anxiety, depression, both? What is your experience with this?
Yeah, absolutely. So certainly it can be any of that. I would say the anxiety and depression tend to probably top that list. We see, depending on who you ask and what studies you read, between 20 and 30% of women headed into perimenopause will expect to experience some mood shift. So some mood fluctuation, even if it doesn't clinically meet criteria for a full-blown major depressive episode or generalized anxiety. But up to a third of women are experiencing a mood shift with those hormonal changes. And the folks who have the highest risk for that are going to be those that have had a personal history. So depression, anxiety, specifically if they experienced that around times of hormonal change earlier in life. So for my patients, when I'm first doing their intake, I really like to get a good sense for what were their teen years like, when their periods first started, what was the mood anxiety situation then, how did they do moving into young adulthood, and certainly around their pregnancies and their postpartum periods, what was that like for them, and even that of their family members too. So mom and aunts and grandmothers, it's really nice for me to know, if they know, how that affected people that they share genetics with. So we know kind of what to expect there, because both of those, family history and personal history, are a risk factor for some of that popping back up around perimenopause. Being a current smoker, low social support, financial strain, lower education level, certainly those are things that we see as risk factors for regular, depression outside of hormonally sensitive times. And also just the severity and the frequency of hot flashes. So that's actually a big one that I know we'll get to. But I know that it seems that is one of the things that tops our list with the most disruptive piece of this transition that tends to be really associated with then mood and anxiety symptoms down the line. And so that is also a risk factor, that if those are starting, and if they're starting early and the more severe that they are, the higher risk that mood and anxiety stuff may follow. And actually during this perimenopausal time, women in general are twice as likely to have a depressive episode now than any other time in their life. And that even goes if they goes for women who have not had depression before. So it can be brand new and they're still at a significantly higher risk for depression than they would have been earlier in life. And it goes to 2.5 times if they've got hot flashes. So that is another big piece that plays into when we see that, because that's super disruptive. I mean, it just affects so many different aspects of sleep and your day-to-day functioning and all this stuff that, it's really logical how that can lead to you end up kind of feeling like you're stuck between a rock and a hard place, and you can see how that would bring up mood, anxiety concerns, a lot of black and white, all or nothing thinking about kind of the way the future is going to go for you. So certainly those are kind of the highest risk people, but I have seen folks all across the spectrum of high risk folks, and then people that you would have said, oh, chances are they'll feel okay. And it still pops up, unfortunately, mental health struggles don't discriminate. So, we do see people with those histories and without.
So interesting. Well, how much of that is completely new onset? We talked about the risk factors, people who perhaps have had depressive episodes before or certain risk factors. What percentage of the perimenopause group that you see has entirely new onset, like didn't see it coming, never experienced this before? What's that been like?
Yeah, I mean, what's interesting about that question is if you had a patient self-report and asked that question, and then if you had me answer that question, I'll bet you those numbers would be different, because I would say probably like pure new onset, truly nothing else in life would probably be a relatively small number, 10 to 20% of the folks I see. But when you ask folks, there actually are so many people who went undiagnosed earlier on that I get a lot of people coming in saying, I've never felt like this, or nobody in my family has had this. And then as soon as it comes up, they go and ask mom, or we go and we talk about what things were like at 13, when they were going through hormonal change, or actually it sounds like your postpartum period was really tricky. Oh, well, that was what motherhood was supposed to be like, or a lot of this gets, I say normalized, I like to say commonized. A lot of this gets just thrown in as part of the experience. And so people don't recognize that it could be different. And they honestly don't get a lot of the appropriate diagnoses along the way. Just part of what I do with some of this education stuff is really just allowing people to figure out what those feelings are and then figure out who can help them with that. Because I think so much of this gets shoved under the rug as the way things have to be. And so while more people would probably tell you it's new onset, I would say truly new onset, probably 10 or 20%, but the people that think it's new onset, I mean, probably close to half the people I talk to, because they weren't diagnosed appropriately the first time around, when this was first seen.
I think that's really good to remember. On that note, just talking about the hot flashes and being associated with mood disorders, I saw a patient on Monday, and I've seen others who fit this profile. We do the PHQ depression inventory for new patients, and our medical staff will notify us with high scores ahead of the appointment so that we can be sure to address that with the patient. And honestly, most of the cases of higher scores that I've seen are directly related to their untreated, undiagnosed, unhelped menopause symptoms. They feel terrible, they're not sleeping, they're flashing and sweating, and their quality of life is so hugely impacted. And they've tried to get help. Perhaps they haven't been able to find it, or perhaps they went to a doctor and got dismissed, or that clinician really didn't have the background to help them. And it's largely situational. I've seen really high scores, and when I dive into it with the patient, it's all about how bad they feel from their menopause that has not been adequately addressed. So yeah, missing diagnoses or commonizing it or normalizing it, this is just the way it has to be. Affects our patients both from their physical standpoint and their emotional, mental standpoint.
Absolutely. And, the data backs that up. We see this kind of waterfall effect that as the estrogen withdrawal gets more significant, the more hot flashes, more insomnia, and then we see more people getting diagnosed with the depression, the anxiety, as their sleep quality and their quality of life in general worsens. And we really they're not able yet to give us good data in the research on, is it a biologic happening that is coming from that estrogen withdrawal? Is it a waterfall effect from how you feel when you're in estrogen withdrawal? And it probably is both, right? The answer with a lot of things is it's multifactorial in medicine, but so much of that is so impactful impactful. That's why it's so great, at least for me, to have you guys to refer to, because that is a piece of the puzzle that I can't take care of myself, and I can prescribe SSRIs until I'm blue in the face. But if we're really not taking care of the underlying thing, that's half the battle, and I know you and I have worked together on folks where we've actually been able to minimize their medications and the intervention that they're needing by actually treating, their underlying hormonal shifts. And I think that's so impactful when you think of just the proportion of the world that is going through this change at any given time, that can make such a huge difference in mitigating what they would otherwise be coming in for as a totally separate issue.
Gosh, yes. When you feel better, life looks better from every
Right.
single perspective. So on the note of SSRIs that you mentioned, I want to ask you, how do you choose a medication? Say you have an otherwise straightforward mood disorder. Among all the SSRIs, SNRIs, how do you choose? Was there science to it? Is there art to it? In our OBGYN specialty, sometimes we call ourselves gynechiatrist because, we see a lot of mood disorders and address a lot of mental health issues with our female patients. That said, I don't know about everybody else, but I didn't get a lot of in-depth training on prescribing SSRIs, or how do you pick which one for which patient? Can you give us some insight about that?
Yeah, absolutely. So when we are talking about kind of this perimenopause world, just to preface, I will say there are two large studies backing Effexor, which is venlafaxine. So that's actually an SNRI, so a serotonin and norepinephrine reuptake inhibitor. But there's also positive open label trials on some of our regular SSRIs as well. So Lexapro, Celexa, Trintellix is a newer one. Now, that being said, a lot of the data that we end up getting in general in psychiatry about what's indicated for what disorders is a little bit of a fallout of kind of what the big pharma industry ends up paying for. So a lot of this is what has it actually been tried for, and it was positive, therefore they kind of bought themselves the indication for depression or for anxiety. If I turned around tomorrow with $1 billion and could test every single med we have on every single indication, we largely expect that most SSRIs would probably meet most of those indications. Most SNRIs, same way. So while you will see sometimes people lean towards Effexor and Lexapro venlafaxine and escitalopram in perimenopause, that is largely kind of a bandwagon effect. The more people that heard that information, and the data is there, to be fair, but it doesn't mean that the others aren't. So when I am looking at a patient, that weighs in, into my decision making a little bit. But because I know I have seen people do great on a bunch of the different medications, I am doing kind of more of what you're saying. It's a little bit more of an art than a science when it comes to this, because this is where the textbooks maybe lack some finesse of how do you choose? There's a lot of options. They kept making new SSRIs year after year. How do we choose? And a lot of this is based on side effect profile. So our SSRIs are generally better tolerated than our SNRIs. And so much of what we're dealing with in perimenopause and menopause are those physical somatic symptoms that the last thing I want to do is start you on a medicine that now gives you a new problem. So now you get to worry about that on top of the other physical things you're already trying to get figured out. So best thing I can do is try to take a gestalt of what you're feeling and where your biggest targets are, and then try to match you with a medicine that I hope will fit in well enough with that, either to at a minimum not cause you new problems, but B, maybe even try to use that side effect profile to our benefit, in that some of the things that you notice are actually good things for you. So in the SSRI class, Lexapro is escitalopram and sertraline is Zoloft. Those are generally the best tolerated first go-tos for folks. And part of that being that in the OBGYN world, we have the most data on sertraline in pregnancy. And so OBs tend to get the most comfortable with sertraline, which is great. But it doesn't mean the other ones won't work. Sorry?
That'll work. That's my go-to, because
that'll work. I've done that before, right? The more you prescribe it, the more comfortable you get with it.
Like, oh my gosh, is that the right one? But I'm so gratified to hear you say that sertraline is a good idea.
Yeah. It is definitely one of the ones that is usually tolerated the best. Of all the things that the side effects that can come from meds, Zoloft has a little bit more nausea than some of the other ones. So if I've got somebody that's like, for example, so anxious, she's like throwing up, or she can't leave her house, or her appetite is so low, I might tend away from sertraline if I'm already dealing with a bunch of nausea and I don't really want to add to that burden. Lexapro, I think, is probably one of the best tolerated ones out there. And so for really anxious people who aren't going to tolerate any new feeling that'll scare them off and they'll stop their medicine, I do like Lexapro. I think it's gentle. I think it does a pretty good job with that. But at the higher doses, which is generally what you need to treat the anxiety symptoms, you usually need more than the entry-level dose. Lexapro can interact with some other medicines and require an EKG if you get really high, so that's a limitation. Zoloft does not require that, so it's great for cardiac issues along the way, or polypharmacy if they're dealing with other medical things right now. Zoloft is generally a pretty safe choice. Prozac, so fluoxetine, another good option, kind of usually next on my list. That one's actually a little activating, so it can be great for couch potato depression, you'll hear us say. So kind of can't get off the couch, nothing sounds fun, very kind of down, kind of the quintessential idea of what you think about depression, kind of when most people hear that colloquially. And Prozac can be great for that. Now, if it's that plus some anxiety, some people don't tolerate that activation very well. It feels like an extra cup of coffee for the first week or two. Some people don't drink coffee for a good reason. So if they're more exquisitely sensitive in terms of activation, I will tend away from Prozac. And Prozac does have, probably of all the SSRIs, the most drug-drug interactions. It goes through a specific liver enzyme metabolic pathway that's a little fussy. So it has more of those. You just got to run more kind of drug interaction tests, on that one to make sure you're not missing anything there, because you can use it in conjunction with a lot of stuff. You just have to dose it more gently. And when you're trying to treat this underlying issue, a lot of times people don't want to wait. You want to be using a dose that's robust enough to do a good job. And if I'm limited by your other meds, sometimes I'll tend away from Prozac for that reason. Other SSRIs, Celexa, Trintellix, again, is the newer one. We've got a bunch in that class. Paxil is an older one that sometimes I will see get chosen, less so in OGYN because there's not a fantastic reproductive safety profile of that. Again, it's pretty old, so the newer data is not as bad, but they just usually OBs don't get quite as comfortable, with Paxil. Frankly, it's the most side effect prone. There's a reason it's old, and we created all these new ones in the meantime. I generally don't use it unless somebody comes in and says, that's the hill I'm going to die on. I love my Paxil. I usually don't start people on it. It's just fussy. There's a lot of physical side effects or sexual side effects, which is always a potential with SSRIs, but more so with Paxil. And it can be fussy if you miss a dose. So usually most of our medicines are actually pretty forgiving in terms of missing a day or two. But SNRIs, so the Effexor that I mentioned, also duloxetine, Cymbalta, and then Paxil, they can be a little dicey if you're not that great at taking them every day. And so for example, like teenagers, if they're just going to be missing 2 or 3 doses a week, an SNRI or Paxil just will make them significantly more uncomfortable. They'll get more headaches and stuff like that, versus Prozac has the longest half-life of all of them. And you can actually get away with a really high dose of Prozac once a week, and it's equivalent to the lowest dose every single day. So if you just have like a teenager where somebody needs to dose them on Monday mornings, sometimes we'll do weekly Prozac dosing. Certainly not quite as effective as actually taking your medicine every day, but I use that as an example to say it's kind of the opposite end of the spectrum, that if you're one of those people that misses it here or there, Prozac could be a good choice for you for that reason. And then I should add the SNRIs, so Cymbalta, less so Effexor, but those also can have a little bit of pain benefit. So they also are used a lot of times by neurologists, and they can have a little neuropathic pain benefit. And so if we are talking about fibromyalgia or a chronic pain syndrome or IBS, stuff like that, an SNRI can be a nice choice. So sometimes, again, trying to get double bang for our buck, we will go ahead and choose something that can kind of do maybe 2 or 3 things for you at once. And sometimes an SNRI is that answer. So maybe you'll put up with the fact that you got to make sure you don't miss a dose to also get that little side benefit off of it too. So plenty of things that go into that choice. Sometimes it's multiple things. And we got, at that point, I like to lean on my patient and say, these are the options. This is kind of what I'm thinking for you. Do one of these 2 options sound more compelling to you? Are you more excited about one of these than the other? And let them help you make that choice. Because the more buy-in you have, the more likely the medicine is to work. So that's usually where I will start. Again, usually with an SSRI if they haven't tried a bunch of stuff before, but lots of reasons to go in a couple of different directions.
I love that. That is just such practical information. It is the art of it. You learn over time, and you can sort of talk to one individual patient and figure out which direction to go. It's kind of like us OBGYNs and birth control pills.
That's what I was thinking. Yeah.
People say, how do you decide which one? Well, some of it's a little gestalt, some of it's side effect profile, et cetera. So there's some similarities there for sure.
Yeah.
So you mentioned sexual side effects. So many of our patients are having issues, sexual problems, either sexual interest, aka desire. Certainly the physical component is something we address right off the bat.
Yeah.
But talk about trading one problem for another. With some of these mood medications, you do have some sexual side effects. So what is your experience with seeing that? What percentage of patients on these will have sexual side effects? Tell us about what those are, and then tell us if there's any way to mitigate them, or do you make medication choice? I know a lot of people will want to be on Wellbutrin because fewer sexual side effects. So talk to that issue, please.
Yeah, that's a great question. And again, a multifaceted one at that. So there is so much that goes into depression in and of itself, but also depression during perimenopause that gets really jumbled. A lot of times people will come in and say, I have this problem, and I already know it's going to take me 10 questions to figure out where that's coming from. And the answer is probably a lot of places. So when we see some sexual dysfunction related to perimenopause, a lot of people say, well, I was hesitant to start a medicine like this because I don't want to make that issue worse. But there's also overlap between the sexual dysfunction from hormonal changes and just lack of sexual interest or anything like that from depression itself. So not even counting the medicine, I already have two places where I could see that problem arising that have nothing to, I haven't even entered the room yet, with my medicine. So there is always the case to be made that we need to make sure we are paying attention to how much underlying illness is still there, because a lot of times it's what you read online and Reddit and social media and whatever. The medicine gets blamed right off the bat. And that's why when I first meet folks, I like to get a good sense for where we are with a lot of that stuff, because I know where we're beginning. So that way, when I add a medicine on, if they are having sexual concerns, is this different than before? Is the medicine actually making this any different? Because I would say for probably about a third of people, they can experience some form of kind of sexual side effects from serotonin medicine. So both SSRIs and SNRIs have the potential for that. It's mediated by the way that dose receptor behavior goes. But based on that, generally what we see is that when people complain of a difference in libido, that tends to be a lot more multifactorial to me than when people say they are having a delayed length of time to orgasm or ability to orgasm. That is more specific with the medication itself. And that is something that is dose dependent. So if I have somebody on an SSRI or an SNRI, I usually don't see those issues until we move the dose up a little bit. So rarely is that happening at the lower doses, which usually is reassuring for people. I'll usually say it's not something you'll generally see straight off the bat. If it happens in the long run, we absolutely have ways we can try to mitigate that, but it's not like you have to choose on day one, oh my goodness, I'm definitely going to have a sexual side effect if I choose to take this medicine to help with my mood and my anxiety. So straight off the bat, if it's just pure libido, could be medicine mediated, more likely that there's at least other factors at play. If it's more specific to the time to orgasm or the function of that, then we're talking probably a little bit more specific to the dose of their medicine. So the first thing I'll try is just decreasing it, right? So if they were doing fine, maybe we took one more dose step up to knock out, let's say the last 20% of their illness that's left over. And that's when the sexual side effects popped up. That's usually an easy call of let's go back down. It doesn't seem like that last 20% of benefit off of the antidepressant is worth the side effect that you're seeing. Now, other people are like, yeah, this illness is so functionally impairing. I wasn't able to leave the house. I wasn't able to enjoy myself. I wasn't even able to be around my family, for enjoyment. And I didn't want to hang out with anybody. So it is much better to me to have that social contact and a little bit of sexual dysfunction than the other way around. And I will say too, by it being dose dependent, the intensity is dose dependent. So it might be that people are willing to tolerate a little bit of worsening of one thing on a medicine for a big benefit, on your mood or anxiety, which was also affecting sexual function to begin with. A lot of times you weigh it all out, it's actually better in the end. So first thing we'll do is decrease the dose. A lot of times that can get us back to not having to worry about that. The Wellbutrin question, I get a lot. So Wellbutrin is a norepinephrine and dopamine reuptake inhibitor. So same mechanism, we're still just trying to make these neurotransmitters more available to the body without adding new ones. But we're using dopamine and norepinephrine that we're moving around instead of serotonin. So because we're not moving serotonin, we don't have any concern for sexual side effects with Wellbutrin, which is great. But so that begs the question, why don't you just use that for everybody? And the reason that we don't is that anything that is norepinephrine and dopamine mediated is going to exclusively be helpful for depression, but not for anxiety. So anxiety is serotonergically mediated, and that does not get better with Wellbutrin. Wellbutrin, and in some people it can actually get worse. And sometimes I absolutely do have isolated depression, but the vast majority of the time I'm dealing with either a little bit of both, or I don't know if you hear this a lot, but irritability, right? I'm raging or I'm
all the
mad
time.
or whatever. And I would say 9 times out of 10, that's the anxiety, not the depression. You know, I think so commonly, and especially with pregnant and postpartum women, it's mom rage or it's postpartum rage or whatever. And they get called depression and they get coded as F53.0 postpartum depression, and they get sent along to the psychiatrist when certainly they're going to the right place, but so often it's anxiety more so than depression. And just by not having the appropriate diagnosis, it keeps them from like getting into the right support groups and calling it what it is to their peers and really getting support around how they're actually feeling so that they can resonate with that feeling and that diagnosis and feel like they are headed down the right path for treatment. And when people say, oh, well, you're probably depressed, and they go, well, I don't feel depressed, but okay, right? I feel different, I feel something's up. That irritability, you know, a lot of times can be anxiety more than the depression. And so in treating anxiety, Wellbutrin is super not the answer. And that is something that I see in tons of well-meaning clinicians. Patients say, I've read on Reddit that I don't want sexual side effects, I want the Wellbutrin, and that will be effective for the depression that's there. But if that's actually a secondary issue and the anxiety is primary, a lot of times they're either not better or actually feeling a little bit more activated on something that's activating, that's norepinephrine, dopamine mediated straight out of the gate. So if it's just depression alone, certainly we can always try Wellbutrin if they could handle a little bit of that activation. So kind of like a different version of what I said about Prozac, a little bit of get up and go. If you'd be cool with that, I usually say, if I give you an extra cup of coffee in the morning, you'd be cool with that. And if they are, Wellbutrin's a fine choice. For other people, it's actually a combination that does okay. So a lot of times I have to talk people through this and then ask them for permission to let me start an SSRI. And then once they're feeling better, if there is sexual dysfunction, actually adding a little bit of Wellbutrin on top of that, so using them in concert, can be a really great solution because that gets you the anxiety coverage you need, starts the mood symptoms off, you know, already getting them better, but then the Wellbutrin adds to the mood boosting effect and can sometimes mitigate the sexual side effects from the serotonin action. So a little bit of a combination is sometimes a really nice fit for people. And especially if they're like, the SSRI did a great job. You know, I'm not stopping it. I would like the sexual side effects to be better, but you're taking this Lexapro out of my cold dead hand. Then we might as well have something else there that we can offer that can help mediate that without them having to choose. So a little bit of both on that, more so if we're seeing difficulty with orgasm and length of time to orgasm and stuff like that. But if some of it too, like you're saying, is purely physical symptoms, that's where I like to make sure that you guys are on board with me, so that if this is something where, you know, actually just a really low dose of an SSRI is all that's needed, there was actually no sexual dysfunction from that. We just needed to get you in to talk about HRT and all of that first. Then we can, again, kind of in concert, have you guys on board with us and actually maybe avoid any additional sexual side effects.
That is so great. That little pearl of wisdom about the anxiety and Wellbutrin not touching it was worth the price of admission tonight. That's
one of those things I would stand on a soapbox about all day long.
I didn't know that, and that is so valuable because most of my perimenopause patients, they identify it as anxiety. They call it irritability, but a lot of them say, I'm so anxious, I'm so anxious, I'm so anxious. And they are.
And they are.
You know, I call it a short fuse. You know, they're getting in trouble at work, and their kids call them the other mother. And the irritability is pretty profound sometimes, and they don't like it, and they don't want to be that way.
Yeah, that's not bad.
Yeah, and so they're looking for help with that, and so that primer on the SSRIs, SNRIs, sexual side effects, all of that was such valuable information. Even if I'm not going to be the primary prescriber, it's good for us to understand that. And because we can also tee a patient up and kind of tell them what to expect and tell them what their options might be. Level set expectations, like you said, Reddit, you know, might have told them one thing, and, you know, you might want to have to correct a few things before they see your colleague. So that was great. Thank you for that. All right. So I think you said the word sleep earlier in this conversation, and I want to talk to you about sleep from your perspective, because it's huge for our patients. And obviously HRT can go a very long way towards correcting the sleep deficiency, which is the cornerstone of a lot of downstream symptoms like body pain and joint pain and cognition and mood and all the things. So a lot of times we're really trying to optimize sleep. From your perspective, what is helpful with that? How do you counsel patients on maximizing their sleep quality?
Yeah, absolutely. And you know, you already kind of hit the nail on the head here. We have to figure out where it's coming from, you know, and I think for a lot of people, they expect like they'll just tell me that they're not sleeping and I will say, here's a pill and that will fix that. And while certainly we have medication options, usually it's not my first go-to. You know, usually the first thing that I start with is like, why? What is waking you up? You know, is it the kids? Is it the dog? Is it the hot flashes? Is it something around the house? Is it pain? You know, is it the snoring dude? Like, what is it that's really waking you up? Because good sleep can be just as impactful as a medicine, right? So I always tell people, like, I talk a lot about postpartum sleep, that like, you know, if I can get you, generally my recommendations, at least 5 hours that touch each other. So at least 5 consecutive hours in a night. That is like the bare minimum that I need new mamas getting to feel functional the next day and keep everybody alive until you can sleep again. And so of course we're aiming for, you know, 7 to 8 in a night, but 5 uninterrupted hours is what I want. And so if something is getting in the way of that, I want to know what that is. Now, some people will say, I'm sleeping for 8, but I went to bed at 7 o'clock. So I woke up at 3 a.m. and I didn't know what to do. And so sometimes yeah, exactly. Sometimes we have to set expectations around that. And that tends to be my older folks of like just wanting to get the night moving, you know, and then they go to bed and they wake up too early. But assuming that it is, you know, 5 hours or less and you are just not getting through the night, what is going on there? So if it is like, no, I could fall asleep at the drop of a hat, but I keep waking up and it's the hot flashes, then chances are I'm having them talk to you guys. You know, if it's, I've got a bunch of pain, like I've got this back pain, nobody's ever looked at it. You know, I don't know if I'm a surgical candidate. I'm wanting them getting looked at for that, you know. If it truly is an actual insomnia, so without another cause, that is first of all primary to their disorder. So then I'm saying, is it tied in with the depression and the anxiety? Were you actually sleeping okay despite the hot flashes until the mood stuff kicked in, you know? Or are you laying down for bed and you are so anxious that you are running through every thought in your brain and suddenly it's been an hour and a half and you're still laying there? You know, is that the issue? Because if we're really talking that it's secondary to a primary mood or anxiety issue, great. I have medicines for that, right? Then we're back to having our SSRI, SNRI, Wellbutrin conversation, because treating the underlying mood disorder will hopefully fix the insomnia, right? Sleep is a criterion, you know, of depression and of anxiety. And so we'll start there. Now, if they come in and they're saying, you know, the other stuff seems okay, but I just really can't sleep, then I'm kind of asking about sleep hygiene stuff, right? So are we in bed, you know, at a reasonable hour? Is it dark? You know, is it dark in your room? Can you actually get a dark, cool room where you are not being woken up by, you know, all these outside factors? Are you turning the screens off, hopefully an hour before bed? You know, are you doing, you know, are you taking a hot shower before bed? Are you doing that? Or are you on the phone talking to somebody who's all stressed out right until you go to bed? Like, what is going on in that hour and a half before bedtime that is leading up to kind of that relaxation time of having your body start producing that melatonin and really start to get ready for sleep? And so if there's some lifestyle interventions we can make, we'll absolutely start with that. And then if we are getting to the point where lifestyle stuff doesn't fix it, the mood, the anxiety is actually under good control, and it's not really physical symptom mediated, then we're talking about just kind of an insomnia unspecified, right? We don't really know where it's coming from. We've ruled out the other stuff. That's, I think, where more of the targeted interventions come into play. So for people that are looking for medication, trazodone, right, is a good non-habit forming option. Gabapentin is actually a really great choice. So gabapentin, and you probably know this data better than I do, at 900 milligrams at nighttime can cover 46% of hot flashes, and up to 2,400 milligrams in the course of the day, even if it's not all at bedtime, can decrease hot flashes by 71%, which was almost equivalent to estrogen in the trials. So usually if it's like fully hot flash mediated, and I know they're not gonna be able to see you guys for a second, I'll use a little bit of gabapentin. And that also has off-label use for anxiety, the sleep, for anxiety sleep, and the hot flashes all at once, or even just for pain or neuropathic stuff, or if there's something else going on. We can get so many different uses out of gabapentin, and generally usually not anywhere close to that 2,400 milligram mark. Like usually my folks, I mean, usually are sleeping great between 200 and 300 in a night, and at reasonable doses, not habit forming, anxiolytic at night, so it helps you kind of calm your brain, allow you to fall into a normal natural sleep. So gabapentin, good option. Trazodone's a good option. We will sometimes use Z drugs if we have to, although I really try to limit those just because of the issues with tolerance and habit formation and stuff, to a couple of weeks to a month or so. So typically that is my short-term option if something's up that's not going to be up for a long time, right? So if this is like an acute loss or an acute stressor, or they do have to wait a little bit to get in with somebody, you know, that can talk to them about HRT, like and they fail the other things, I'll use a bigger gun if I have to, but with very clear expectations that this is a short-term thing. We're not trying to make this a forever. I'm not trying to give you a new problem now where you can't sleep without this thing I gave you. You know, and then if they're really interested in a longer term solution or not interested in medicine, CBTI. So CBT for insomnia is really powerful. So I know we'll really talk about therapy here in a second, but one of the routes that we can take CBT, or cognitive behavioral therapy, is specifically focused on insomnia and what these cognitions are around sleep, or these we call them sticky thoughts that people cannot shake, right? That I will never fall asleep, or my sleep will always be this bad, or I'm always going to have to function on 4 hours and I will never do my job well, or I'm gonna get fired, I'm so tired. Those types of things are real sticky, and that'll keep you up, right? You're thinking about sleep, you get anxiety about anxiety, and then it's just like a rat on a wheel. You're running, and it's hard to get off. So CBTI, or CBT for insomnia, is a specific modality. Even within kind of the umbrella of CBT, it functions a lot like a course. So I like to tell people who maybe aren't, like, maybe they've never done therapy before, they don't really want to sit on a couch and talk about their mom. That's not what we're doing here. This is very much skills-based, identifying that triangle of thoughts, feelings, behaviors. What are we telling ourselves, maybe without even realizing it, that's getting in there, getting its hold, you know, and really kind of exacerbating this problem that maybe otherwise is as simple as turning the thermostat down or something like that. So CBTI not only is very effective at the end of 8 or 12 sessions, whatever you choose to do, but it's also really longitudinal. So if you have the skills, it's like riding a bike, right? If you end up with sleep issues in 10 years, you'll know exactly where to go. You'll have those notes, you'll have those reminders, and you can go right back there. Your therapist can do a booster session with you. You know, that's something that can be picked back up at any time, versus a medicine works when you take it and doesn't work if you don't. CBTI you'll always have. So that's usually, spoiler alert, it's my spiel for all CBT, but like, it is a real big investment in your future, in that not only do you get the skills you're looking for, you've done 10 years from now you a favor at the same time.
I love that. We're always recommending CBTI. There's an app. I don't know what you think about the CBTI coach app.
Yeah. That's usually where I have people start. Yeah, it's great. It was created by the VA, generalized now. It doesn't look like a VA product anymore. But it's really great. It has 4 different little quadrants. When you open it up, there will be like all the sleep hygiene stuff I'm talking about is all in there. If you put your sleep into that app for a few nights in a row, it'll give you a sleep prescription, which is cute. It kind of tells you, like, seems like you need to be in bed at this time, so you can wake up at this time, whatever. It will give you ideas for what to do if you can't sleep. So basically, another sleep hygiene piece of don't lay in bed and not be asleep. So get up, but it's boring stuff. So it's like, count your socks, and, you know, go read the biggest book you can find, and like stuff like that. And that, like, you know, it isn't like count sheep. It wants you to go do something physically, so you're out of the bed, which is a good piece of this. Don't associate the bed with insomnia, but it gives you something that's super freaking boring. So you're not sitting there like watching a good TV show or whatever. You're doing something that is dull, and if you're tired, hopefully, you know, that fatigue will set in. And then it gives you ideas for what to do if you're too tired and you're falling asleep at the wrong time. So for some people where they're not sleeping at night, but then they're so tired at 2 o'clock in the afternoon, they're taking a nap, and then they can't fall back asleep, it'll try to help you reset those types of things. So that's a great option. It's free. It's pretty much generalizable to most of the issues that people will come in around insomnia that are common. And it's a nice place to go from there, because I've had people who will start with that app and then go, okay, you know what, that's actually really helpful, but I wish I was doing it with somebody. And so then they'll be open to doing CBTI, like with an actual therapist in person or virtually. But it's a great foot in the door for people who are hesitant or just kind of want to know more about it. There are some just psychoeducation pieces in there where you can just read about it. Like, it's all you got to do is read and see if you like it before you even use the app. So I love that one. I think that's a great one. There's a few other ones that charge for it. Slumberland or Slumberco or something like that is one that charges, but is a good way of walking you through that. And then of course, there's actually a lot, at least in Austin, there's a good amount of therapists that are also trained in CBTI. So if you're really looking for that, usually a quick Google search will bring up people that really have good training.
That's such good information. And we're getting close on our time, believe it or not. And I do want to leave some time for questions. But before we do that, we talked about therapy. I want to talk about your mom therapy that you said we talked about. So what is the role of therapy in your perimenopause and menopause patients? Do people embrace it? Do they resist it? And how do you work with a group of therapists, or do you do some of that yourself? Tell us your perspective on the couch.
Absolutely. Yes. So when people say therapy, they can mean almost anything. It's like saying, you know, I'm an artist, right? That could mean hundreds and hundreds of things, right? So when we have people come in and we recommend psychotherapy, I usually talk to people about what exactly it is that I'm recommending, because just saying you should find a therapist is borderline useless. So the gold standard for anxiety is CBT, is cognitive behavioral therapy. So I will talk to people about that triangle and why I think that's effective a lot. That's probably the one I recommend the most. That's very skills-based because it's behavioral therapy. It's very skills-oriented, much more like a course than an endless kind of longitudinal thing. It is isolated, so you can go in saying, hi, I want to do 4 sessions with you around my anxiety about flying on an airplane and I want to leave. And like, that's a reasonable way to start that process. So that is usually one of the first things that I talk to people about. DBT is dialectical behavioral therapy. So that's another kind of, again, skills-based behavioral intervention for depression, anxiety, but it is much more coping skills-based. So while CBT is a little bit of like a higher step up the cognitive rung of like, what am I thinking? What feelings are coming up because I'm thinking this thing, and how do I shift that? DBT is much more, how do I cope with this thing that I can't change? And that actually, it sounds somewhat basic. And I know a lot of people, if there are clinicians here that have some experience, a lot of times we associate DBT with like, oh, well, that person just can't tolerate feeling sad or something. But in this realm of patients, I find it really useful because there's so much about perimenopause that we can't change. Like, even if we can treat a lot of it, we can improve a lot of it, there are going to be some things that maybe just for that specific person, or even the length of time that they have to tolerate something, it's going to be there, and we can't fully get them out of whatever that feeling might be. And so really having skills to say, I accept this, it's here. One of the therapists that I like to work with says, let it get on the bus. So it can get on the bus, it can sit in the back, but it doesn't need to run your life. So it doesn't need to change your behavior. It doesn't need to keep you from going out, seeing people, doing the things that you enjoy. And when it is on the bus, how can you tolerate it being there, right? What are things I can tell myself? What are things that do make me feel better behaviorally? Getting outside, getting in the sun, all of that, getting, a support group, seeing my friends, like getting that connection with other people. What is it that's useful to me? So part of that is DBT skills-based. Part of what I just described is also ACT, acceptance and commitment therapy. And that's very much kind of identifying the things I can't change and working around them, rather than trying to really parse apart, why do I feel this way? I don't want to feel this way. It's really allowing that to sit and accepting that that is here for today. It's not going to necessarily be here tomorrow or a week from now or a year from now, but today it is. And I want to go to dinner with my friends. How am I going to rectify or reconcile those two things together so that I can still have a quality of life that I'm comfortable with? So you'll hear me. So a lot of the stuff that I'm talking through is behavioral stuff. And I think that's very front of mind for things like this, because we're talking about a lot of physical symptoms, a lot of stuff that is new and that is functionally impairing. And so that's usually my foot in the door for somebody who's brand new to therapy, but open to it, because that's a lot of times where they see benefit more quickly, is with a behavioral aspect like that. So we'll start there. I have some people who start there and say, I wish I would have done therapy 20 years ago, and they really benefit from it. They like having that support. And so that's where, and this isn't generally a conversation I end up having. Sometimes I do with my folks, but a lot of times the therapists are talking to patients about this, but saying, awesome, do you want to go a little further? You want to go a little higher level up? Do you want to do some more of that, what we'll call psychodynamic psychotherapy? So talking about kind of maybe how things from your past influence things that you're thinking now, how the people in your life, experience things and how therefore they influenced you. What does it mean for you to be kind of going through these life transitions? I mean, a lot of this, we say we're depressed or anxious. You get down to the crux of it and it's like, there's a lot of meaning to menopause. And what does this mean about myself and my body and my relationships? And, how do I think about myself, and how do I conceptualize the next, potentially 60 years, of my life that I still have ahead of me, when in reality, a lot of society tells us like, you're in menopause, right? Like, see ya. Like, that's, you no longer, are a valid part of society to really be allowed to say those things out loud, and I think getting to the point where you've got the skills, you can kind of tolerate the here and now. Who wants to go a little farther than that? Who wants to maybe talk through some of that and get a little bit more understanding of why you feel the way that you feel, and therefore how to affect change and how to interact with, your peers and your family in a way that's really meaningful to you. So that is a little bit more of like them talking about your mom on a couch. But for some people, that's really impactful. And for other people, they're like, I'm good. I got my breathing skills. I got my coping skill toolbox. I'm good. Like, I'll see you later. And so a lot of times psychotherapists are having that conversation with patients about next steps, but sometimes they'll come to me and say, I've been seeing Sarah over here for a while. She's great, but like, I don't feel like we're making as much progress as we used to make. And that's sometimes where I will sell that. I don't do a lot of my own psychotherapy. I used to. Now I do a lot more of the medication management, just because there's more of a need for that, or less people that are able to do that. But we have a lot of really fantastic clinicians in our community. There are people in my clinic as well, over here, rpcaustin.com, who are able to provide that service in a kind of reproductive psychiatry focus. So that's what they do. That is where their training is. They've seen people in these different changes of life. It's kind of what they focus on. And so I'm able to refer to people that I really trust to do a good job. I know they'll get a good quality of care there. But many options. It kind of depends on what we're looking for, which is why, there's such a wide breadth of types of psychotherapy we can send people for.
That's such great information. It strikes me so often in our menopause population, women have all these roles. We have our role as a parent, perhaps. We have a role at work as a spouse or partner. And then throw in the mix, we have aging parents and perhaps kids at home, younger or teenagers or young adults. And so often the menopause transition brings up so much of the various roles. Now, what is my role? Now my kids are going to college. Now what? The empty nest syndrome, the sandwich generation, trying to take care of the elderly and manage your own life as well. And so there's so many situational things that come in at midlife. So I'm a big believer in therapy, helping people kind of work out how they feel about themselves and what the future looks like. And I had an office manager one time, she's very wise, and she said, there's not a person over the age of 12 who hasn't needed a therapist from time to time. And I really think that's true. And so I encourage my patients to seek out some type of counseling, support, therapy of whatever type is going to be beneficial, maybe through their employee assistance program or other resources. And honestly, a lot of my patients who come in, they're already seeing somebody, which always makes me very happy that they have that support. So it's a big piece for a lot of people in navigating midlife.
Yeah, absolutely. You do not have to hold a psychiatric diagnosis to spend some time in psychotherapy, just learning more. If you think of it as just more exploration about yourself, there's no way that you're going to come out wishing you didn't do that. So
exactly. And the other thing I loved about what you said was a get on the bus concept. It's on the bus, but it's not driving it.
Yeah.
I might use that. I might find myself using that with patients. So thank you for that. All right. I want to invite questions. If anybody has questions to put in the chat, now would be the time to do that. And Nicole, is it RPC Austin?
Yes. So we have of course, we expanded outside of Austin. We do see people across the state of Texas. So rpcclinic.com and rpcaustin.com now take you to the same page. So both of those are accurate. But if you see us and you see people like all our marketing folks will, they'll put up RPC Clinic usually, but they go the same place now. So that is us. If you yourself or have patients who are interested in this type of care in the state of Texas, we are available.
That sounds great. Well, I put those two things in the chat if anybody wants to take advantage of that resource. Thank you. All right, so a couple questions coming in. The first one is, when it comes to medication, is it better to start with an SSRI med or go straight to estrogen? I don't want to say all of the above, but go ahead.
Right. That's such a great question. And I know this is like the answer that rolls her eyes, but it depends. It depends on the person, right? So if I am hearing a longitudinal history of depression, anxiety, if their pregnancy postpartum experiences were rough, if they've never tried a medicine before, I'm more likely to be like, I really think there's some benefit to be had for you. I'm hearing reasons why maybe I could have probably given this to you 10 years ago. Let's try this out. And at the same time, let me put in the referral, for you to talk to your OB or talk to Jenna or whomever, and see what that feels like to you, versus if they come in and they're like, I'm fine other than the fact that I can't sleep through the night because the hot flashes won't quit, or my joints, nothing, everything hurts. Like I can't sleep because everything hurts, if it sounds super physical to where, and I will ask people, if I took XYZ components away, what would be left over? And they'd be like, oh, I'd sleep all night long. Or I'd have no problem, or I would want to get on a plane and go to Hawaii. Cool. Then I may defer, I may go ahead and say, start there. I want to meet you back in 2 months. Let's see how you feel when they're able to start stuff. And if there's still symptoms left over, because a lot of times we work together nicely, right? There are pieces that you guys can cover for, and there are pieces left over for us. Sometimes though, it is completely one or the other. So I will, if they are amenable to it, if the symptoms are not, overwhelming, safety concerns, all that stuff, I will wait. I'll wait and see. If I think most of this is hormonally mediated, I'll kind of wait and see, versus if it does seem like there's a history or there is stuff, there's hopelessness, like there's stuff that I'm more concerned about, then I'll say, let's just start both. And if we can pull the SSRI down at some point, we will, but I want to hit the ground running, and then we'll do both at the same time. So I think it depends on the person.
Sounds great. I want to read this comment by our medical director, Dr. Rebecca Dunsmore-Sue. There are studies showing estrogen and SSRI are equally effective for depression/anxiety in the perimenopause. After full menopause, depression responds better to the two together than either alone. So there's our all of the above approach. That is really good information. Thanks, Becca.
Absolutely.
All right, so you and I can both address this. I'll see if you have any comment, and if not, I'll take it. What is the role of progesterone in sleep help for women with anxiety?
Oh, great question. So progesterone, okay, and I'll leave the medical side of this to you. The progesterone for a lot of women is a little sedating. And so that's why you guys generally dose it at night. And so I've had some people come in and tell me mild to moderate improvement with sleep just because of the sedating properties of that. But both estrogen or progesterone itself is not an evidence-based treatment for the anxiety. So that is not something that is typically going to be useful in the long run. Now, if we need to go ahead and give them estrogen and treat perimenopause, then certainly it can affect anxiety, but progesterone alone is not an anti-anxiety treatment. So I will have some people that say, I was started on progesterone. A lot of times I get a shoulder shrug because it's probably an SSRI needing situation, where maybe it's made a really small difference, but for the most part, that is not an evidence-based way of addressing the anxiety. So we don't start there. And for folks that are needing, frankly, progesterone coverage for the estrogen that you're prescribing, we leave that to you guys. So we actually do not prescribe estrogen or progesterone from our end of things. We leave that to you guys for the HRT purposes, and which does line up with the fact that most of the data for what we're doing is still left in our realm.
That is great to know. I'll make a couple comments about progesterone. We obviously need it in a woman who has a uterus who's going to be on estrogen. And I tell patients the one job of the progesterone is to protect the endometrium from overgrowth. However, it can support sleep, so we dose it at bedtime. But I try to make it clear that progesterone is not indicated independently as a sleep aid, because some patients come in asking for it as a sleep aid.
Yeah.
Or patients who have had a hysterectomy and they don't need it, they still want it because it's, will help with sleep. And I really try to talk them out of it because there's some risk involved in taking the two together longer term that we don't have to incur because we can optimize sleep in other ways than taking progesterone for sleep. But certainly it is very nice to dose it at bedtime for women who need to be on it. It's kind of a bonus benefit, I would say. Yeah. All right, a couple more questions. Dr. Scott, do you have any recommendations for supplements that you recommend, such as vitamin E, maca, magnesium glycinate? What is your perspective on supplements?
That's a great question. I get asked that a lot. That is because a lot of people that have seen other folks before me, right? They've spent a lot of time on the internet and asking around and seeing what their friends found helpful and all of that. And a lot of times over-the-counter stuff is a low bar, of entry just to kind of see, is this going to work for me? There is, mild data for some of that. So magnesium does have some data for anxiety, can be helpful with sleep depending on the formulation you choose. Maca, I've had a few people anecdotally find that helpful. I think there's, again, a mild amount of evidence there. By the time I end up seeing people, they are generally to the point with their symptoms where they're needing more robust treatment than supplements can offer. So assuming that it's not something dangerous or the uncharted water from the internet, like something where I don't know what's in it. Sometimes they'll be like, I got this from another country. And I'm like, I don't know. But other than those types of things, I don't discourage people from doing the supplement stuff that they're interested in, they feel is helpful. But generally from my end of things, I'm not recommending those just because the effect size is too small. So if I'm going to spend time seeing you and giving you your options, I know you're going to get more bang for your buck out of psychotherapy and a low dose of Lexapro than me spending a month waiting to see how the magnesium does, and then spending another month waiting to see how the next thing does. I don't think it's a bad idea to add in a supplement, that assuming it's not something that, again, that's detrimental in some way. But for the most part, I don't spend a lot of my planned time talking to people about that, just because I have things with much more robust evidence behind them. And that's why they're there to see me. And so we will usually start and end there. But people will, add in whatever they find useful in them for themselves. And sometimes that is some of the magnesium and things like that. And they can be nice little supplements, but rarely are they solving problems for people to the point where they're talking to me about it.
Exactly. That tends to be our perspective at Genève too. And there's so many things that may not hurt somebody, but you want to level set expectations about what kind of benefit they will have for you. Good. All right. It's probably time to wrap up. It's 8 o'clock straight up in Central Time. Becca, did you have a comment? I see your hand raised.
Yeah, sorry. I'm not coming on camera because I'm not camera ready tonight. I just wanted to add something to the progesterone discussion, because I think it's important to remind people that there are a certain subset of patients who have a paradoxical reaction to progesterone. So it can make their anxiety much, much worse. So these are the patients who often we see have pretty significant PMDD or PMS. So just be cautious with using progesterone in these patients, because sometimes you can make the situation worse, not better. We talk about it as being sedating and soothing, but there's probably 5 to 10% of the population where it's the opposite.
Absolutely. That's such a great point too, because so many people that come to me have already been, around the rodeo with some of that stuff, and the people, I'll always tell them, the people who are more sensitive to exogenous hormones, they're still going to be more sensitive to exogenous hormones. If that was pregnancy and postpartum and they had issues then, like, chances are there's going to be a little piece of that if they weren't experiencing mood symptoms, they could see a little bit of that depending on how sensitive they are. It's a great point.
Such a great discussion. I wish we had another hour because we could keep going. I think that means we just need to book you for another webinar. So I hope you'll come back. Thank you so much.
Thank you for having me. This has been so fun. I loved it.
Thanks everybody for attending, and keep in mind, again, this is going to be recorded. And so please feel free to share with others. And to the people watching the recording in the future, please sign up for our additional webinars. You can find those on our website, and we'll look forward to seeing everybody in the future. Thank you so much.